All right. Welcome, everyone, and thank you for joining the DxQI Sea Grant Program Informational Webinar. My name is Jerry Castro. I'm the Director of Quality Improvement here at the Society to Improve Diagnosis in Medicine. And we want to welcome you to this webinar where we hope to answer some of the general questions, tell you about the grant itself, and then help provide some guidance around what to expect in applying for a grant, and also if you are in fact awarded a Sea grant, what to expect as far as participating in the program. So let me start with the purpose of the Sea Grant program. The purpose of this program is to stimulate innovation in the field of quality improvement, especially around diagnostic quality and safety. Diagnostic quality and safety is an area where we've been lagging somewhat as opposed to more mature patient safety issues. We hope to elevate the importance of addressing diagnostic quality and safety within healthcare systems. And so I think that's an important message to take home. We want healthcare organizations to be able to do this kind of work. And ideally, the Sea grant will support that within your organization. So every year, when we are on the third year of this grant awarding program, we award up to $50,000 grants to support specific quality improvement work. And we'll talk a little bit more about that, directed towards improving diagnostic quality and safety. Overall, this grant program is supported by the Gordon and Betty Moore Foundation. So we are very grateful for their support. So let me go to the next slide, and I'll let my colleagues introduce themselves. Go ahead, Jan.
Well, good morning or afternoon, wherever you are located in this beautiful country. My name is Jan Mangan, and I'm a consultant for CITM. I have been working with the Sea Grant program since 2020, when the world shut down, and it's exciting now to be starting the third cohort. I'm available to you for any questions or assistance that you need, and look forward to having some great applications this round. Suze?
Did we lose Suze?
We may have.
Oh, yes, it looks like we did. Okay, so I'm looking through the participant list, and it looks like Suze disconnected. She was here a moment ago. So let me do her introduction for you. Suze Schrant is our senior patient engagement advisor here at CITM, and she has been the voice of patient and family engagement here within our organization and throughout all of our programs. I will say on Suze's behalf that what we try and do with all of our programs here at CITM is to bake in patient and family engagement. So that is a very important component in this program, and actually in all of our programs. So Suze will explain what that looks like and some of the experiences with the grant application. So, all right, let's move on. So our agenda for today, we're going to cover specific focus areas associated with the grant program and the application. So we'll talk about the eligibility, the three categories or focus areas for the Sea grant program. Talk about within the application required components, and I cannot stress this enough. There are some required components that we're going to be sticklers about, and then we'll also talk a little bit about the scoring criteria and the process for review. We'll also go into additional resources that may be beneficial as you prepare the application. Finally, closing out with important dates, and then of course your questions. So as I mentioned in the chat, if you have a question in the while we're going through the material, please feel free to drop it in the chat, because if you're anything like me, you have a thought and then you forget it by the end. So go ahead and just pop it in the chat, and if we are able to do so, we'll try and answer it on the fly. So let's start with the Sea grant program eligibility. So as I mentioned, we are focusing on healthcare organizations, and we're pretty specific about what we're talking about here in that we say healthcare entities that provide direct patient care. Okay, so that's an important component. And you can see the list of different types of organizations here, but in the note, what we also specify that you can partner with other types of organizations, such as medical equipment companies, labs, state hospital associations, educational institutions, so on and so forth. So those, as we get into the grant application proper, we would consider those third party, supporting supporters. But the main applicant has to be a healthcare entity that provides direct patient care. So this is all specified, I should say, also in our RFP and FAQ. So you don't need to rely on the slides or this presentation here for the detail of this information. So the types of interventions that we're looking for can be described in one of four categories. And so if you can read this by yourself, but what I'll say is that it runs the spectrum from a well-defined intervention, right, that we know about in the field of quality improvement, that will be tested and improved, and it has to be focused on quality improvement towards diagnostic, improving diagnostic quality and safety. So then we can go down the line, there's an implemented, evaluated intervention that will be tested within a different setting, or an implemented but unevaluated intervention, and then so on. And then finally, with the final category of intervention, a well-defined problem, you have to do a little bit of discovery work, finding out a little bit more, and then an adequate to be defined intervention that will be tested and improved. Now, it's important to note that within these different categories, there should be multiple cycles of testing. So if we think of our traditional quality improvement model of PDSA, there should be multiple cycles of improvement built in within your plan that fits within the different types of interventions. So here's a list of different intervention examples. I know one of the questions that we received was specifically about, can my application focus on an educational intervention? And the answer is yes, but they have to be, where the targeted outcomes of the studies are improvements in diagnosis, and ultimately, and demonstrating the ultimate outcome or recipient of that education is the patients and their families. So educational interventions are an important component of improving diagnostic quality, but we want to be able to see what is the outcome. Can you demonstrate an outcome, a patient-related outcome, and or how, and specify how the patients will benefit. And I will also add here that within the different types of interventions, you need to also, to the extent possible, describe how these learnings and improvements will be sustained. So here are some non-qualifying examples. So and just from the experience of past cohorts and past applications, what I will say about these different examples in general is that we need to see how patients benefit, right? And I mean that's really the overarching message with these examples. For examples around like new interventions in the lab setting, without testing them for impact on patient care outcomes. So clearly there are innovations within the lab that can improve diagnosis, the accuracy or timeliness, but it has to demonstrate what is the outcome to the patient. So in this particular instance, maybe there's an improvement in the lab, and then you can run it through the healthcare system or continuum and show, here's how it translates, and here's how it's communicated, and ultimately here's how the patients benefit in some sort of metric. I will also say that these are quality improvement interventions. Okay, so that's an important distinction. It's not scientific research, and we found this link here, which I think does a very good job of distinguishing between what is quality improvement and what is research. Yeah, I will say that in research, it's very structured. With quality improvement, we're given a lot more flexibility, and so that's one of the hallmarks of our grant program. We work with the grantees, and we are flexible in trying to to determine what is the best way to help you improve. So let's move on to the specific focus areas. And so you can see here that we focus on the big three: diagnostic quality disparities, and then we leave a certain proportion of grants open to an open category where it's not specified with one of these specific priority areas. Within the big three, if you're not familiar with it, I encourage you to check out the article by David Newman Toker. And the big three are vascular events, infections, and cancers. With diagnostic quality disparities, we are fairly broad in what we consider a diagnostic quality disparity. So we look at age, race, ethnicity, gender, and other social determinants of health. And in which case, this could be disparities between urban and rural. This could be, different other types of disparities that we have not focused on or are listed here. I will also say that proposals can focus on both the big three and diagnostic quality disparities. And I'd say that if your proposal does in fact do that, then that would be more beneficial. It's kind of like a plus for your proposal or your application. So as in the past cohort, we are focusing more on diagnostic quality disparities. So if you're familiar with cohort 1, we did change the proportion a little bit up and from cohort 1 to cohort 2. So, but like I said before, if you can focus on both the big three and diagnostic quality disparities, that would maximize your chance, assuming that you have a high quality proposal. I will also mention that new to this year, we would like to focus on older adults. So if your intervention or proposal focuses on older adults, and I'm thinking specifically of like the Hartford Foundation's age-friendly healthcare model, that's something that we want to start putting a little bit more attention there too. I will also say that, at the top bullet there is a great resource for you. If you're looking at what does a disparity in diagnosis look like, there are foundational readings on our webpage. So let's go from transitioning from the different categories and focus areas. Let's dive into the application's required components. And this is just a quick outline of what's required in the application. There are questions, there's a simple budget. We'll really focus on the executive sponsor letter, and then of course third-party support letters if you decide to partner with another organization. A diagnostic process diagram is new to this year, where you will specify where in the diagnostic process your intervention seeks to address a problem. And then of course, as with most grant application, there's a bibliography. So let's jump right in to the application component about the budget. So the budget is really simple. It just focuses on the project team, materials, travel, and indirects. So we are capping the indirects at this limit of 12.5% of your direct budget, because if it goes much more than that of $50,000, that's not a lot. So that being said, this is also a limitation of our funding mechanism from the Moore Foundation. We are capped at 12.5%. So similarly, we pass that down to our grantees. If I recall correctly, I did receive a question specifically about funding of project team personnel. And I think this was via email. And yes, it is okay to fund external or additional project team members, like an advanced practice nurse or a research assistant, that kind of thing. So yes, absolutely. But the important caveat here is that it's not intended to fund work that you should be doing, and that's a point that we'll reinforce a little bit later. So, okay, well, let's go right into what the grant won't fund. So, here we talk about major capital expenses such as equipment, supplies, or IT infrastructure. So we have received grants in the past, or grant applications in the past that look at that without any, and it just, as a grant reviewer, you kind of look at this and it just seems that, oh, well, they're just asking for stuff, right? For lack of a better word. It has to be, the focus is on intervention, right? Quality improvement intervention, and not so much on equipment. We won't fund sub-grants or travel to other conferences. There is a requirement, I should have mentioned this in the previous slide, a requirement for travel to our annual conference, and it's more to support meeting and meeting your fellow grantees, and then also to learn more about diagnostic quality and safety at the conference. So as I mentioned, we will be including an indication within the application where your intervention will work within the diagnostic process. And if you're familiar with this diagram, this is the National Academy of Medicine's diagnostic process diagram. The link is there. And if you're not familiar with this, I highly encourage you to check it out. But it specifies the different points at during a diagnostic process where there's intersections with the patient. There are it specifies components of the diagnostic process. It talks about different work systems, and then ultimately being able to share that diagnosis with the patient. So there are multiple places in which there can be diagnostic failures. And at the top there, you'll see whether it's a failure of engagement, failure of information gathering, integration, interpretations, and so on and so forth. Communicating that explanation to the patient. All of those are important components which a diagnostic quality intervention can address. So if you think about this in the typical patient safety sense, you identify a root cause, right? And those are at the top. It's a failure of information gathering, right? Or failure of an integration. Then your intervention seeks to address that failure. And so you will demonstrate how your intervention addresses that particular root cause. And so that's the intent of us including this diagnostic process diagram, because it just helps us be a little bit more specific as to where in the diagnostic process. And it's also to say that the diagnostic process is broad. I mean, broad in scope. And if you look at previous grantees, some of them look at it, in total, right? From admitting the patients to getting them, specialty care and paying for that care. So, or it could be very focused. So this will help us determine where in the process it will impact. All right, so as I've been kind of mentioning at the beginning here, the letters of support and the particular the executive sponsor letter. So this has been actually, to be quite frank, this has been problematic for previous applicants. We will have an executive sponsor letter where they don't attest to any of the things that are important. So that we've created a template that specifies the 7 elements for which an executive sponsor must commit to, and we will expect that letter to be uploaded through the application system. And so failure to attest to all 7 of these points could be grounds for disqualification. And so we're gonna be a stickler about this for this year, because last year we didn't provide a template and we weren't we were explicit, but I guess not explicit enough. But it's there. The template is provided. You can have your executive sponsor sign off on that letter and use that as a part of your application. So yeah, I'll stop there. And with that, I will transition it to my colleague Jan to talk about the application criteria.
All right, well, thank you, Jerry. This screenshot is from the seed grant landing page on the CITM website, and it provides a nice way to access the information needed for this grant application. You can see there are 4 tabs at the top and in this section, and if you click on any one of them, you will get more detailed information. Jerry has already covered the program requirements and the what we are looking for tabs. So the next few slides will provide an overview of what is being requested in the application and how that translates into how the grant proposal will be judged. Next slide. The first element of the application is your aim statement. This statement is really a foundational part of the grant. I mean, it sets the whole tone for the grant because it's designed for you to describe what you want to accomplish in the 12-month time frame for this grant period. In other words, what is the desired outcome for your project or intervention? Generally in QI, you only see 1 or 2 aims, but we want to see that those statements address all 5, what we call SMART elements. And SMART stands for specific, measurable, attainable, realistic, and timely. So for example, a name statement might be, over the course of the next 12 months, through a structured exercise and nutrition plan, I will lose 15 pounds. So it's specific, measurable, attainable, maybe, realistic, maybe, but definite and timely because we've set a limit. So I guess I'm just, again, looking back over some of the applications we've received in the first 2 cohort rounds. A word of caution, you need to address more than just your intervention, what you're going to do in your aim statement. So for example, it needs to be more than, we're going to build a CDS tool in our EMR. Okay, that's fine, that's your intervention, but what is it that you want to accomplish or improve, and to what measurable degree? So it needs to be more than what you're just going to do. It needs to be what you want to accomplish or improve, and to what measurable degree. So we don't want to see a specific aim for each step of your plan. Those are milestones, and they will be provided in a different section of the application. And as I mentioned, measurable is important, and it refers to some type of quantitative or qualitative goal, as in the example I just gave you. And if you need assistance or you're not familiar writing aim statements, the FAQs provide a link to the IHI Science of Improvement Setting Aims document, which will provide tips and contains a number of examples beyond what I just gave in this webinar. So the next section is to define the problem that you're looking to address and the background to that problem. Why did you choose this issue to focus on? Provide the background, describe the magnitude, both locally within your own organization or community, as well as nationally. Establish its importance and relevance to the diagnostic process, as Jerry already mentioned, by referencing the diagram mentioned earlier. And literatural citations will need to be provided to support the significance of the problem you plan to address. The next section is to describe your intervention and rationale. This is where you will describe what your chosen intervention or tool will be that you plan to develop and test. How well does the proposed intervention address the problem's root causes? include the ability to sustain this change over time, whether it can be spread and scaled to other populations, settings, or organizations. And if you're addressing the big three and/or disparities, describe how your intervention will specifically impact those focus areas. Next slide, Jerry. Okay. Judges will be looking for a detailed description of how you plan to accomplish your aims. You will begin by defining the population that will be included in your intervention. Again, you want that to be consistent with the aims. Describe the change methodology you plan to use. So some common QI change methodologies are, for example, PDSA that Jerry mentioned. You can be a lean organization, DMAIC, or use the ISO 9000 family. But describe that in your project plan. You will be asked to provide a timeline for planning, implementing, testing, evaluating, and improving your intervention. And you really want to give serious thought to, is your timeline reasonable and appropriate? And that the judges will be looking at that very carefully. And as I've already mentioned, how will you measure your effectiveness, either quantitatively and/or qualitatively? In most cases, that's going to involve operational resources and data availability. As part of your measurement strategy, you will have to determine how you're going to obtain the necessary data to determine whether improvement has occurred. So ask this question of is the data already being collected and reported in a manner that will enable you to analyze it for your purposes or not? If the answer to that question is not, then you need to describe your plan for obtaining the necessary data. Does the data collection process or system need to be built or installed? How will you collect the data? How will it be retrieved? If fields need to be added to your EMR or some other IT program, how will you get that done? By whom? And you're going to need to consider how long it will take to be built and when it will be user ready. So, and one last point about data. Data does not necessarily translate into information out. So you need to be sure that your data is collecting usable information for the purposes of your project. Next slide. Organizational rationale. In this section of the application, you'll be providing us information about your project team, the core team. There will need to be a project lead. There can be co-leads and then other members of the team, what their roles, training, and experience are, and in that, what the essential qualifications they provide to help you achieve your aims. The team should be interdisciplinary. It should include a member that represents patient family engagement. That there should be, and we will expect to see someone or more people with QI expertise and experience to help you through the project and change management process, and IT support specifically if you are going to be involving some type of IT intervention. Next slide. The final two parts of the application include risk and risk mitigation. There will always be potential negative unintended consequences that could result from your intervention. So include whatever balancing measures that need to be put into place to determine whether negative consequences have occurred. And all projects will experience challenges or run into barriers along the way. You can count on it. We've had one full year of experience and with this cohort, and believe me, you can count on running into challenges or barriers. So projects are more likely to be successful if those are identified and a plan developed for how you will mitigate them should they occur. Regardless of whether you are dealing with a pandemic like we are now, things like the inability to obtain needed resources, hiring freezes, IRB hurdles, competing time demands, personnel turnover, all those things can occur over the course of this year. And if your intervention will require committed IT time, such as if you are planning to implement some type of CDS tool or develop some type of AI intervention, then you really want to be sure that you have addressed that. Because those resources are easily pooled to other directions in your organizations. And finally, it's not part of the application, but the judges will be providing an overall general impression of your application as part of their review and scoring process. They're going to be looking at whether your grant meets the intention and how well it's been written. They'll be looking at timeliness, how realistic is it, and how sustainable, spreadable, and reproducible it is. So keep those things in mind, because the general impressions will be shared with the final grant review committee as well. And next slide. Okay, with that, I'll turn this over to Suze, who will talk about the patient and family engagement component of the application.
Great, thanks so much. Great to be with all of you. I'm Suze, and I serve as the Senior Patient Engagement Advisor for CITM. Just going to talk through the patient engagement requirements and provide a little bit of framing and hopefully help outline, what it is we're looking for and how best to describe this in your proposals. So just right at the top, the reason this is a requirement is because we really believe that patients and families have an invaluable role to play, and that just makes good sense. We as patients and families have the most to gain from diagnostic quality, and certainly are the ones who get harmed if we have poor diagnostic quality. So it just makes good sense that we craft these interventions in partnership with patients and families and really build them out to be as impactful as possible. As you see here, we want you to describe engagement in a couple of dimensions, and I'm going to dive into that in just a moment. And then if you don't feel that patient or family engagement is possible, or you're not sure how it would be beneficial, we'd really like you to talk through that reasoning and why you think that's the case. So let's go to the next slide. When I mentioned the sort of two dimensions of patient engagement, I'm going to give you sort of a nice just vernacular to use to help distinguish here. There is a real challenge in the language that we use because the term patient engagement means a lot of things to a lot of people. So the type that's been around for a long time that people often mean when they use the term is the engagement of patients in their own care or in their own diagnostic experience. So at the point of care. And that's certainly very, very important. And we want you to think about that and contemplate that in your proposals. But the other type that is a little newer, this has been around for almost 2 decades, but it's taken a long time to catch on. That's patient engagement that really looks at patients and family members as partners in efforts to improve the system that serves them. This is not at the point of care. This is not their own care experience, but it's using all of that lived experience and wisdom to help design interventions, conduct studies, implement, et cetera, et cetera. But the real import here is that lived experience is absolutely essential. I often say innovation without patients is just guessing. So you really want to partner with patients in these meaningful ways. So let's go to the next slide, and I'll just walk through an example of what this could look like. So let's say what you're looking at is a closing the loop tool. And I'm sort of going through an entire QI from creation of the intervention all the way through to evaluation. as Jerry described, your project might be a more discrete part of that journey, but I'm just outlining this as sort of a start to finish QI initiative. So let's say to develop this closing the loop tool, you want to have your idea and rationale for the project. Then you, of course, create and plan the project, and then you execute and evaluate the project. So it might be hard to think about how you would engage patients or families in that type of work. But let me give you just a sort of scratching the surface on what this could look like. So let's go to the next slide. Okay. And I think advance once more, because there we go. And one more time. And one more time. Sorry, I didn't know I had some animations. I apologize. So I'm going to draw your eyes down to the bottom kind of lavender box. And we're going to start with the type of patient engagement that you're probably more familiar with, and that really the entire healthcare system is more familiar with. That's that type A engagement, that point of care engagement. So certainly in a project like this, you would want the patients who are using a close the loop tool, or for whom this tool would be used at the point of care, you would want to be actively engaging them in that process, making sure everything was very understandable, accessible, maybe even asking them for real-time feedback, asking about the ease of use of the tool, making sure it really was responsive to their needs in that diagnostic journey, in that point of care. But let's zoom back to what it might look like to use type B engagement. How do you get there? How do you get to a tool that's actually helpful and important to patients? You do that by partnering with patients from ideation all the way through to execution and evaluation. So looking at the very top, if your project was about the creating the intervention around this issue, you absolutely need to get patient partners in the room. And this could be an advisory committee that you form. It could be the Patient and Family Advisory Council at your hospital or health system or other institution. If you're looking within a particular diagnostic area, you can always reach out to patient advocacy organizations to recruit patients with relevant lived experience. And what you do then is think of these people as not only sort of active partners, but as just treasure troves of data. They can tell you what went wrong in their diagnostic journey. So if we're looking at closing the loop, they could share the barriers that they faced with follow-up. They could offer solutions on what would help. They could provide input on that proposed tool, what it might look like, how it would be as impactful as possible. If you're looking at creating the intervention, how that would work in practice, here again, those same patient partners help with understandable language, feasibility. What should the patient-facing components look like? They could troubleshoot issues with buy-in, with challenges to the use of the tool. When I think about closing the loop, I think about what about certain patient populations who are going to feel invaded? They don't want text messages. They don't want to be sort of pinged or bothered. How do we troubleshoot that? By talking to patients representative of that community. Think about inventive, creative ways to get around some of those barriers at the start, not when you're trying to figure out what went wrong after implementation. And then finally, maybe your project is really looking more at executing the intervention and evaluating its use. Here again, those patient partners are going to be crucial. They're going to help with ongoing troubleshooting and revision. Really importantly, and I think this is probably maybe most surprising to people, patients can be phenomenal partners in data analysis. It's often patients who point out trends or themes in data that others might miss. You see a little blip, you think, well, I wonder why there was a drop off here in use of the tool or in people's evaluation of the tool. Patients often have very quick answers based on that lived experience. So you really want to just cast a wide net and really offer the patient partners the opportunity to decline if they don't want to be involved in a particular part of your effort. Generally speaking, patients can be involved in every single part, and they will tell you if there's a part that maybe they're less interested in or seems maybe not relevant to their interest. So let's go to the next slide. With all of that framing, what do you do when it comes time to actually write your proposal? keep those two types of engagement in mind when we're reviewing these proposals. I don't know if it's been mentioned yet, but there will be patient and family members reviewing the proposals as well. They're going to be laser focused on what this looked like, what this section described. So you want to be thinking about the patient partners that are involved at the point of care. What does that engagement look like, if that's relevant to your project, if it's something that's going to be rolled out with patients? And then how were patient partners involved in the project itself, in developing the intervention, if that's what you're doing, in evaluating the intervention, if that's what you're doing? No matter what the effort is, how are patient partners going to be involved? Try to be as detailed as possible. It's not very helpful to just read, "We will engage patients." That just doesn't give us a good sense for what that could look like or who those people are going to be. And then lastly, if you don't feel like engagement is going to be possible or it's not going to be beneficial, really, really important, given how much we care about patient engagement, that you articulate that case well. It's rare that I see a proposal that I think, yeah, there's no way to engage patients. So if you really feel like that's the case, you want to state that argument quite well so that we really understand what those limitations are or why it wouldn't be beneficial. And one last thing, I saw coming into the chat a question about outcomes relevant to caregivers, family members, et cetera. And I just want to make it clear that when we say patient engagement, we really mean patient and family engagement. And certainly for those specific populations like pediatric patients or maybe frail elderly patients, the caregiver is really proximal to that diagnostic journey. So we think about sort of patients and whomever their care support teams are as all important potential partners. And I think that's the end of my slide. So I'll be here to answer questions if any come up.
All right, great. Thanks for that, Suze. And sorry for the delay. I was responding to questions. So just to start wrapping up about the application, here are just some other considerations. You must confirm that there is no additional external funding available to do this work. So that means that these grants are not intended to be small parts of a larger research efforts. I mean, certainly you can carve out a particular research question within a larger project. Maybe there's a subset question, but this is not intended to support externally funded work. IRB. Wow, what can I say about IRB? Other than I'm sure you have, as healthcare organizations and research organizations, I'm sure you have dealt with IRB. Ensure that they are involved and aware early on. We have struggled with organizations that have either, their IRB becomes aware of their proposal late, and they actually, stopped the proposal from going forward. We have had an organization deny, return the funding, that they cannot take the grant because the IRB was not aware. So, get those processes started as soon as you can. And there is a stipulation here that awardees will not receive funding until IRB issues are resolved. You can start the process, and since these are quality improvement projects, you will probably receive a waiver. But again, get that process going as soon as you can. Other considerations. So these are more programmatic things. If you are awarded, we expect grantees to attend the cohort kickoff webinar. And that's more of the going over the program details and what are the expectations. We would like the submission of bi-monthly status reports. And sometimes we give folks a pass on that just because there are quarterly meetings at the same time, but they're meant more not as a formal reporting mechanism, but more so just a status check. How are you guys doing? Is there anything that we should be aware of? And I will say that there are formal mid-project and year-end reports, which those are the more document where you're at, what do you need help with, what are the barriers, and ultimately when you're all said and done, how did patients benefit from your intervention? We also expect grantees to participate in quarterly calls. And really, this is just an opportunity to learn more about your fellow grantees and the cool work that they're doing. I find that I learn a ton whenever I participate in these quarterly calls, and everybody wants everybody else to succeed. And so it is just a supportive community of grantees. And so that is an opportunity for that kind of collaboration. And then attend 2 designated QI summits associated with the annual conference. So I mentioned that budget requirement in the grant proposal, and that's to fund your attendance at the QI summits. Now, I will QI summits preceding the annual conference. I will say that in the past, though, because of COVID, we have had virtual conferences, and so it's not as great as being able to meet somebody in person and collaborate that way, but we've had to make do as everybody else.
Jerry, if you don't mind, I'd just like to kind of emphasize,
please,
these expectations are really not onerous, and the reports that you have to submit are pretty generic and short. I think they're like 1 page, just addressing what your status is at this point in time. But the participation in the quarterly calls and the QI summits is something you really need to make a commitment to do. And when you accept this grant, you are making that commitment. Maybe not so much as a publicized intention, but I think a real important intention behind this grant is to build this community of work around quality improvement in diagnostic medicine, and that community comes from you all getting to know each other, sharing what you're doing, being able to scale, spread, reproduce this work in some fashion around the country, and to build on the foundation that these cohorts are setting. So I really want to emphasize that there needs to be a commitment to participate in this work, which comes through your executive sponsor, but the main person is going to be the project lead.
Thanks for that, Jan. All right, so a little bit about the application review process. I know this was kind of mentioned throughout, but there are multiple rounds of, starting with a technical review, which is performed by staff, which is Jan and me, to ensure that the application meets the intents of the grant, the criteria that are specified in the RFP and FAQs. After that, they goes through multiple rounds of peer review, and as Sue's mentioned, including patient and family engagement review. So that is, as I said, that's an important component, and they, folks will comment on the proposals. Finally, 30 of the finalists are advanced to the grant review committee round, which is convened as an in-person meeting where we go through the different applications and the issues that are being addressed, and then from there we determine the awardees. If you're interested to see who's actually doing the judging, it's available on our website. I encourage you to check it out. But once all is said and done, the applicants and awardees, applicants and awardees will be notified by July of this year. So at least we're targeting that, But I will say, with this timing, we, as with quality improvement, we're building slack into our process and the ability to be flexible. So, just if anything, you will be notified of any changes in that kind of scheduling. Here's the available resources right now. Well, I should say the RFP and the FAQ are currently available. We will be opening up the application portal next week, I believe, or at the end of the month. And with that, we will also release the instructions to complete the grant application. So be on the lookout for that. Check out the website for those resources. And then finally, I just wanted to close out with some proposal writing tips. And so, these are the things that we look for. And, just from past experiences and reviewing these grants, these are just the tips and tricks that we came across. And let me pass it to Jan because she does a really good job of explaining this.
Yeah. Well, thank you, Jerry. With this being now the third cycle of the Seed Grant program, we learned some things from the first two rounds of applications and review. First of all, really develop a quality application. Read and answer what is being asked as clearly as possible. Now, some of you may have come from organizations where you have grant writers and these people, that's what they do. So they are, applying to grants all the time. And so there's a tendency to cut and paste often, but just be sure that what is being cut and paste actually addresses the question that's being asked. This grant is not intended, as we mentioned earlier, to subsidize people to do the job that they were hired to do. To acquire a medical equipment that did not get approved in your capital budget, or simply to hire more help for your workplace. Again, we can't emphasize enough that it's really about, it has to impact patient care improvement through the diagnostic process in some way. Remember the attainable and realistic attributes to your SMART aims in developing your goals and intervention. And nothing taught us more about that than going through this whole COVID pandemic so far. And also, especially if you're incorporating some type of IT intervention, make sure that part of your plan is well thought out. If you're not familiar with, if you're new to grant writing, we don't necessarily provide training on grant writing, but we provided some resources here that are available to you to help you with that. Next slide. Okay, so these are some important dates. The application deadline, well, as Jerry mentioned, we're opening the application the end of this month, and the deadline will be March 25th. We hope to have the grant review committee and the award announcements done sometime before the end of July, and to allow time to get all the contracts signed and everything ready to go. We anticipate cohort 3 grant period starting in September and going this year, going through September of next year. Next slide.
Okay, and here's our slide about questions and answers. And as you can see from the chat, we've been trying to answer these questions on the fly. So to provide us, you guys, the answers. If you haven't looked at the chat, please do check it out. Once we make the recording available, we will make a copy of this chat available too, or at least, just maybe a summarized responses to the chat. There are also formal mechanisms for asking questions. You can send us an email to dxqicgrant@improveddiagnosis.org. And, it does say I'll receive questions and answers, but I do think, between Jan and myself, we can do some consolidation or even summarization too. So, yeah, and I see there's an ongoing discussion. There are great resources from PCORI about stakeholder compensation. Brian, the question about the deadlines was on the previous slide here. And let's see. Very good. Yeah. All right.
There was a question, I think, from Brian about if we don't get chosen, will we get feedback from the rounds? If you fall into the final 60 of the applications, you will get feedback. Okay. Let's see. I think there was one question that I wanted to address earlier. I think there was a question about retrospective data analysis. Is it okay to not have patient engagement? Well, first of all, I think that retrospective data analysis is not a quality improvement intervention. And so you really need to think about what is it that you're going to improve with this retrospective data analysis. How is that going to translate into some improvement in the diagnostic process? And frankly, off the top of my head, and Suze and Jerry, please chime in. I'm not sure if you don't include an intervention, if it's going to meet the qualifications of the grant. And if you do, then I find it difficult to understand ways in which you couldn't include patient-family engagement. Jerry, you have anything to add?
I'd say, if anything, there are ways that you can get patient feedback on retrospective data analysis. Specifically, unless it's like super technical, right? Yeah, I mean, maybe there are, what are the important things to be looking out for within a data set, or, specifically, what is important to the patient to know about, within the data, that, and start from there. Maybe Suze also has comments on how to accomplish that specifically, but I see she's muted. Oh, and I know we're running up on time, and I'm sorry, Foja? Am I pronouncing your name correctly? Sorry if I'm not. Please go ahead.
Thank you. So yeah, it's fine. I'm Fazia, and thank you very much for this opportunity in this detailed presentation. I just have one question. We applied in the last cohort, although we were not successful. But the one thing is, there is this very specific question for patient engagement. So my question would maybe directly to Suze, that since I'm from Pakistan, this is low middle income country, and we have maybe, in a very embryonic stage for the quality and patient safety. So our intervention might be very groundbreaking in our part of the world. But there is a one component where we really need to justify that this intervention going to be maybe similarly effective or impactful in USA. So when we rationalize that portion, that the intervention, for example, making call to the patient for the patient engagement might be a very fruitful thing to do in our part, because it's like a really non-existent in this part of the world. But when we want to apply this in a similar fashion in USA, it might not be that fruitful. So how could we address that? The thing that is like a very the intervention that might be very impactful from diagnostic perspective in my part of the world, and I need to address this rationale that how it could be impactful in USA. I hope I explained my question.
I will take a stab. I'm not sure I followed all of that, but I would just say, if the goal is you want to adapt a tool that existed in a different population to the US population, I would work with relevant patient partners to do those modifications and think about what would the different contexts be in a different healthcare system, with different cultural contexts. I think you can. I think it actually would require a significant amount of patient engagement to sort of do that massaging and modifying for a new geographic location and a new patient population. I'm not sure if I really got that, but we can also respond to that in the large Q&A if you want to submit it in the chat.
Sure, thank you.
Any other questions? Okay. So with that, folks, I want to thank you for your participation. It's always wonderful to see the interest and as you submit your applications, the different types of projects that are out there. This is a very broad space, and we want to be able to catalyze and to spread your work. So this is a great opportunity for that. If you do have other questions, feel free to reach out via that email address. There's also a mechanism through our website. So please do reach out to us with any questions, and we will try and post the responses online as well. So thanks again for your time, everybody. And with that, I will close our webinar.
Yeah, and Jerry, I think there was a question about whether the recording will be posted. It will be posted to the website. Yes, along with the Q&As when those are ready.
Mm-hmm. Very good. All right.
Okay.
Thank you, everybody. Take care.
Thank you all. All right. Enjoy the rest of your day.